This is Dr. Howard Strassler presenting an e-lecture on decision-making in restorative interventions, Module B, Class II caries and preparation, design considerations. We start by reviewing the definition of a Class II. Class II refers to smooth surface caries on the proximal surfaces of posterior teeth, where the caries progresses as a wide base at the enamel smooth surface, extending to be a cone, the tip of the cone reaching the DEJ, caries then spreading along the DEJ and then penetrating into the dentinal tubules with a leading edge as the tip of that cone, of that triangle. The caries continuum, as we've described in the past, is based upon the concept that the enamel demineralizes and remineralizes and is in an equilibrium, where the sound tooth structure, referring to enamel, is kept mineralized. As acid attack occurs, we see a histological evidence of caries in the enamel, followed by radiographic evidence of caries in the enamel at half the thickness to the enamel, especially readily seen on a smooth surface lesion for a proximal using a bite wing radiograph. The caries extends radiographically within the enamel until the dentin is histologically affected. And the enamel maintains its intact surface. It may be discolored, brown, whitish, white spot lesion. The caries lesion continues until finally we see definitive dentinal caries, until finally we see a slight enamel cavitation and the indication for placing a restoration. So let's take a look at interventions for Class II interproximal caries, where we see no occlusal caries and no cuspal involvement, but rather we're restoring this tooth because we see radiographically the presence of interproximal caries, or clinically we see a cavitation on the interproximal surface. We can break this lesion really into two distinct entities. One where there's absolutely no caries on the occlusal, but the pits and fissures are susceptible. When we see susceptible pits and fissures, we're going to do an occlusal access as a proximal slot with an occlusal sealant. We may decide to do an amalgam. We may decide to do a direct composite resin. There are times, though, we can do a more a less invasive preparation where we do a facial access, and we'll show examples of that facial access. But here we're looking at proximal caries with no occlusal caries, no cuspal involvement. If the occlusal is susceptible, we'll use a sealant on the occlusal. If there is no occlusal involvement, we don't need a sealant. And once again, all the risk factors as we determined for occlusal caries, pit and fissure caries, Class I caries, falls into effect in how we treat that occlusal surface. And so we're looking at a proximal lesion with no occlusal caries, but the occlusal is caries susceptible. And we're looking at a child, an adolescent, someone in their early 20s. We look at the invaginated groove or the pit and fissure. All the things that we're talking about when we talk about a Class I. What differentiates it, though, is there's a Class II proximal lesion that's cavitated. Radiographs indicate decay. In fact, if we look at the radiograph to our right, we can see caries in the enamel, and you can see a leading edge of dentinal caries in this radiographic image. We may or may not see staining on the surface, but we're going to look at all the historical evidence of fluoride, dental hygiene, diet, presence or absence of restorations in how we make our decision to intervene. For the mature tooth, the adult patient, we'll look at pit and fissure anatomy. We'll look at the cavitation on the proximal surfaces, all the things we just talked about. Radiographic evidence, staining, fluoride history, dental hygiene, diet, presence or absence of a high carbohydrate diet or acid diet, or presence of restorations. And in fact, for this patient, an older adult patient, a more mature patient, we see a cavitated lesion On tooth number 12 on the distal surface, in fact, an explorer will find that that surface is cavitated and rough. Notice there's no evidence of occlusal caries. This patient's in their 50s. In fact, for this patient, they had class 2 caries on the distal in number 13 that was restored with a slot preparation and an amalgam restoration a fair number of years ago. But there was no need for an occlusal preparation other than the proximal box. We do our diagnosis of caries really based upon the radiographic appearance. We need a diagnostic X-ray to look at a proximal surface without any overlap on that proximal surface. In these two radiographic images, you can see the red circle is pointing to the evidence of caries radiographically in the enamel and penetrating into the dentinal surface. Certainly, a larger lesion is present on the right-hand side on tooth number 4. Our radiographic diagnosis shouldn't be limited to focusing on just the caries, but the acceptability of other restorations that are present in the mouth. In this bite wing radiograph, we can see that tooth number 13 has an existing amalgam restoration with a radial opaque base underneath it. There's a class 2 distal carious lesion that's obvious on the radiograph. When we take a look at tooth number 14, we can see that there's an overhang on the DO, distal occlusal restoration and amalgam. And if we look at the lower permanent molars that are seen on this bite wing, we can see that the other class 2 restorations in the mandibular molars and the second premolar are well contoured with well adapted gingival margins of the class 2 amalgams. So we look at this radiograph. From this radiograph, do you see any problems? Does anything catch your eye? Take a look and take a few seconds to systematically look at this radiograph. And typically, what I'll do is start on the left and view the maxillary arch, left to right, noting the presence or absence of pathology. I drop down to the lower right-hand corner and moving from the posterior on the left-hand side, which is the right of the radiograph, I look at, in this case, number 19, then number 20, and I make some interpretations and observations. And so you look at radiographs and you make decisions based upon absence and presence. I'm going to go back to the last one because on tooth number 13 I notice a distal carious lesion. I notice that there's an overhang on the distal margin of the DO on tooth number 19. Let's take a look at this radiograph right here. Do you notice any problems? Do you notice any pathologies that are present? Once again, starting from the left-hand side on the maxillary arch, and then I drop down to the mandibular side. And bite wing radiographs do give us evidence of horizontal bone heights. What jumps out at me when I look at this radiograph is when I look at tooth number, in this case we're looking at tooth number 14. On the mesial amalgam, I see a significant overhang in excess. I see the potential presence of recurrent decay, and when I replace this amalgam, I'll see if this in fact is caries or an artifact. On tooth number 15, I notice a slight distal overhang that perhaps I can recontour. When I drop down and take a look at tooth number 18, I see a mesial overhang on the amalgam that may be able to be contoured. I see an occlusal amalgam on tooth number 19 with the presence of a very thin base. And I make decisions for my interventions based upon this radiographic appearance and comparing it to my clinical evaluation. And caries isn't just limited to permanent teeth. Here we're looking at primary molars with class 2 carious lesions, and perhaps an initiating lesion on the distal surface where the green arrow is present. But we're seeing that there is caries present that needs some level of intervention. And so when we're making restorative interventions for class 2s, for that young tooth, for the younger patient, where there's no occlusal caries, we'll probably do an occlusal access proximal slot, or perhaps a facial access that looks almost like a class 3 preparation, but from the facial surface. We can restore it with composite resin or amalgam, with an occlusal sealant for this younger patient, where the tooth may be at risk of occlusal caries. For the older patient with a more mature tooth, where we see minimally isolated caries, we may decide to do a PRR, a flowable composite. If the caries extends into the pits and fissures, we'll do our class 2 interproximal preparation with a full conventional preparation with composite resin and amalgam. And so our interventions based upon presence or absence of caries and the decision whether or not we'll use a sealant using the same criteria we used for class 1 restorations, class 1 sealants. Our proximal slot preparation where the caries was present with retentive grooves in this proximal slot. Considerations toward the use of amalgam or composite resin for this young tooth. We can consider facial access preparations, and I'll show you later what those facial access preparations look like. And here we're looking at a facial access. A sealant would be placed on the occlusal, and the preparation is just done with a facial access. It is still a class 2, but it would be considered a mesial facial in this instance. The more mature tooth, we won't use an occlusal sealant, but just our proximal slot design, with considerations for placement of an adhesive composite or an amalgam restoration, but no need for a sealant on a tooth that's shown resistance to occlusal caries. And so, for that case we saw previously, where we saw a class 2 carious lesion on the distal surface, it was cavitated, we're doing a proximal slot preparation. We can restore this either with amalgam or composite. There will be retentive grooves placed, and you can see that we're leaving the occlusal surface intact. The mature tooth, once again, no sealant. An older patient, the tooth's been erupted in the mouth for over 25 years. Even though this is the same picture conceptually, that our preparation can maintain and leave the marginal ridge intact. We can restore this proximal with composite or amalgam. Our matrix, in fact, would be an amalgam matrix band that's cut in half and would slide through this proximal surface with a wedge placed, and that we'd place the restoration from a facial approach. So extension for prevention for this preparation depends upon the extent of the occlusal caries. For the occlusal access proximal slot, our extension for prevention, in fact, may be a sealant. We want to include all carious areas, and our proximal retention would be into the buccal and lingual walls using a quarter round burr. And the proximal slot may not need an occlusal preparation. We may be able to visualize the caries better on tooth number 12 using our digital radiographs and processing it to get a better look at that proximal lesion. Look at the difference at the image as it first presented, and then after digital processing. And now we can see the enamel wall is broken through and that we can see the dentinal caries. We see a better contrast and sharpness to this carious lesion. So we look at occlusal slot designs for the class 2. Our preparation here, and this is flipped, we've not included the occlusal. We've broken contact on the lingual. We've visually broken contact on the buccal and then restored with amalgam. But we've maintained the fissure on the occlusal surface as not being restored. Or for this patient, diagnosis is a distal occlusal caries. In fact, the marginal ridge is broken below the carious tooth structure. We'll later see this in our e-lecture on restoration with posterior composites as to how we progress with the technique. But the occlusal surface is intact with this mandibular second premolar, and our preparation doesn't need to include the occlusal surface. It's strictly a slot preparation. Wedges are placed to compensate for thickness in the matrix band to get rapid separation. We pre-wedge these teeth, and we restore them with an adhesive composite resin. What about the facial slot? Well, when we're doing a facial slot preparation, it is more difficult to evaluate complete caries removal. We may need to transilluminate the tooth. We don't need to break proximal contact with our composite resin occlusally or lingually. Gingivaly will break contact because, by definition, class 2 caries initiates at the below the interproximal contact, so the gingival margin will be broken from the adjacent tooth. So we have a cavitated lesion on the distal surface. It's been prepared, contact hasn't been broken, and for this tooth we'll be restoring it with composite resin. When we see occlusal caries and occlusal caries through the isthmus, it changes the types of restorations we can plan for class 2s. So we're looking at class 2 interproximal caries with occlusal pit and fissure caries. That's into the dentin. Our consideration could be a full occlusal preparation and a proximal slot preparation that are joined together to give us a composite resin, either as a direct composite or a composite inlay. We can do a cast gold inlay. We can do an amalgam restoration. In some instances, we can do a proximal slot, and in fact, in the isolated carious areas, do a preventive resin restoration, placing either it with direct composite or in some cases amalgam, although if you're doing a PRR, in all likelihood, you'll use a direct composite resin. So let's take a look at this case. We're going to do a conventional cavity preparation design of the outline, including extension for prevention. Using a Diagnodent, a digital caries detector, we determine that this is a carious fissure on the occlusal surface. At the same time, we see a defective amalgam restoration on number 19 on the occlusal surface. We do our cavity preparation design, and we're using a 245 burr. A typical 330 burr is 1.5 to 2 millimeters, and we can't prepare a proximal box. You can see that the caries and, in fact, the fissure extended into the occlusal surface, and we can see some staining of where the pits and fissures extended into the dentin. We do our conventional preparation design for that. And we look and we evaluate, and class 2s aren't just caries lesions but defective restorations. So we're looking at some class 2 amalgam preparations and restorations that were done. You can see the wide occlusal isthmus and the MOD on the second premolar. But notice the defective margins on the buccal of tooth number 4 and on the distal facial margin of tooth number 5. We're going to replace these restorations because of the defective margin. Or for tooth number 19, radiographically it has caries on the proximal surface, and there's caries on the occlusal, but only in the mesial portion. So caries is going to determine our final outline form for 19, but 19 will be considered an MO preparation. We go in with our burr and we prepare our proximal slot, and we're doing some occlusal preparation. Mandibular premolars, especially first premolars, give us greater challenges, and our preparation design will be more of a occlusal with a proximal slot or a proximal slot alone. In many cases, we don't need to go through the transverse ridge. So your final outline form is determined by the extent of the cavity. Dovetails only needed if caries extends into the fissure in the mesial or distal fossa, And so our design will have variation depending upon the extension of the caries. Each tooth has a unique outline form determined by the extent of the pathology. So we take a look at how deep the caries can get and how it would extend based upon our radiographic diagnosis. Whether we'll need any liners or bases as part of our restoration, those determinations will be made. Keep in mind that when we see deep caries, we're going to be assessing pulpal vitality, getting the patient's history, so we can understand where we're going when we're doing our preparation and our treatment. There are times for Class 2s that we may decide to do inlays and onlays. We can do composite resin, ceramic, cast metal. We can do CAD/CAM restorations as part of our procedure and to conserve tooth structure to keep a tooth from having a crown. For our preparation design, we're going to use tapered fissure burrs to do our preparation to create a path of draw, to create divergent walls. You'll learn more about inlay design, about CAD/CAM restorations in other courses. But for this patient, we did some gold inlay preparations, and these restorations were done in the early 1980s, where the patient had existing caries, and we prepared these teeth. The patient desired a gold restoration, and the preparation was made divergent so that there is a path to draw for the restoration before it's cemented. In today's world, these perhaps would be digitally impressed and imaged, and we create a CAD/CAM ceramic or composite restoration. In later coursework, you'll be learning more about the use of inlays and onlays. For this preparation, in this patient, the patient had unesthetic amalgams and wanted them replaced with tooth-colored restorations. Through the use of composite resin inlays, we can restore these teeth. Decision-making and treatment planning for restorations of posterior teeth starts with the correct diagnosis. From there, your preparation design and selection of restorative materials will fit the given circumstances with discussion with the patient. You've been watching and listening to Decision-Making and Restorative Interventions, Class 2 Caries and Preparation Design Considerations.